Welcome to the Beverly Hills Plastic Surgery Podcast. I'm here with my rather obnoxious co-host tonight, Dr. J. Calvert. You missed me. I almost tried to smack him. He's being obnoxious tonight. But you know what?
Not.
Welcome anyways.
So glad to be here. I mean, with an opener like that, let's get right into it. You know what that makes me do? It makes me go like this.
For the listeners, he is grimacing, which is an adequate lead-in to the topic of tonight, which is platysmal bands.
And there they are.
And there you are. And for those who are not versed in the term platysmal bands, what this references are those lines and those bands that form in the neck when you try to grimace or make a funny-looking smile. These bands, I have like a gazillion of them pop up and move. Okay, maybe like...
You got two.
I have a lot. And it's not necessarily something that happens with age. I've had mine since I was in my 20s. Women that work out a lot, that have a lot of like muscles and upper body muscles, sometimes they tend to get overdeveloped. So it can be congenital. It can be from muscle hypertrophy, but it can also just come from age as well.
Yeah, so the platysma, the word platy means flat. So the platysma is a very flat, broad muscle in the neck.
And can we talk about the horses?
Sure.
Yeah. So the platysma is analogous to very superficial skin muscle that horses have. Have you ever watched a horse, out in the stable or out in the pasture, and their skin like twitches and flinches as they're trying to get the flies off of them? It's kind of an involuntary movement, and it's due to this very superficial muscle, which is analogous to the platysma in humans. So it's literally like right under the skin of the neck. And so any little flinch or twitch or movement of the neck or the jaw will cause these muscles to activate.
Yeah, and we see them in humans pretty, like they just kind of hang there and they get worse with age and it's time. I know.
Yeah.
I know.
They're obnoxious.
You just have to go. They are obnoxious. Just like your co-host.
Just like my co-host.
So, yeah, the platysmal bands, like everybody talks about them, and I will tell you that it seems like you could just cut across the platysma and get rid of them, but it's not really that way, is it?
It's not really that way. And if you are to go through the volumes and the years and the journals talking about facelifts and neck lifts and how do you address and treat the neck, you will find so many different ways and ideas and concepts on how to treat these bands, because typically they are addressed when you're talking about a neck lift or a facelift. You can address them in isolation, but most of the time it's when you're doing a neck or a facelift. That's when you really open the neck and you look at the muscles and you devise a way to treat them, and how you treat them and how you fix them and how you address them. There are a plethora of options.
Yeah.
And there's a plethora of options because none of them are great.
They're really, so first of all, the platysma muscle heals and it grows back.
Really quickly.
Yeah, these muscles of facial expression, the neck muscles, especially these, very flat, superficial muscles, like they grow back and they heal. And they, like, so cutting it, yes, that helps, but I think the way that, so what is it? Why are we dealing with it? So these platysmal bands, they go basically from the chin down to the clavicles. They can be out laterally as well. They can kind of be underneath in the submental region, in that area between the chin and the hyoid bone, which is what we call the angle of the neck.
The central neck, people, central neck.
So anyway, the bottom line is that, like, I tend to go in and clip them out. I tend to cut them out, cut them in half, take wedges of platysma out, cut the entire platysma across, and move the platysma to the lateral position. So all these ways have to be custom tailored to the patient's neck. It has to be you have to spend some time diagnosing what the problem is, why the platysma bands are prominent on said individual, and then devising a treatment plan that will max out and give them the best result without, the worst thing that I think is if you core out the neck completely and make them look like a bobblehead. And then it looks like the head is stuck on a post, which I have friends that everybody they look like that. And they're very proud of it. I was like, they look weird. They look like cadavers. And there's all this like push to do this deep neck work right now. Take out the glands, take out the platysma, cut the anterior belly of the digastrics in half, take out the digastric muscles, throw it all away, which you can do. It's surgery. It's not hard. Like if you're a surgeon and this is what you do, those things aren't difficult, quote unquote. And there's this, like aggressive sort of over resective thought process going on in a lot of plastic surgeons' heads right now. And then when you look at their patients, they really look strange. It's not cute. And they're proud because they're like, look, I cleaned that all out. I was like, yeah, and your patient looks like iRobot.
I mean, everyone has a look, and some people really like that. So there are definitely surgeons, and there are definitely patients for those surgeons who do all of the above. And I think for this podcast, this is going to be a little technical heavy. So this is geared maybe a little bit towards young surgeons, trainees, because I think we should go through a little bit, the different techniques. Because if you are to go, even as a patient, go on Instagram or social media, you'll hear people talking about all of these different techniques. And so, listener beware, it's going to get a little technical, but let's go through some of the different techniques, starting with some of the more old familiar favorites like platysmoplasty. Let's talk about that.
Yeah, I mean, we can definitely do that, but I want to give you a little asterisk on that comment, because my patients come in and say, you need to take out my glands. You need to take out my submandibular glands. I need them out.
But that has nothing to do with the platysma.
No, I know it doesn't. But I'm just telling you that these terms of how to treat the platysma, that's all on social media now. And there are facelift surgeons and neck, face, neck, whatever you want to call. There are plastic surgeons and facial plastic surgeons that are, and that difference people can figure out for themselves, but they are pushing technical maneuvers as differentiating whether they're good or bad at doing these operations, rather than saying what we're going to do is make a diagnosis and evaluate you and customize an operation to make you look your best. And that's dangerous, because then everybody's goes in thinking, I need my glands out. I need my platysma muscle cut in half. I need my digastric muscles, sent to the pathology department. That's not true. Everybody needs something different, and you need to customize it so that they look their best and not look like they've had plastic surgery.
Okay.
Are you good with that?
I'm good with that.
All right, so back to the platysma. So this flat, broad muscle, the platysma, spanning from up on the face down to the clavicles, right? It's all of this. You can see it. I think the best thing to do in most cases is to wedge out the portion that's in the middle of the band itself, and then either do a little bit of a corset platysmoplasty. Is that a term I can use, or are you gonna come after it? So that's when you sew the platysma muscles together in the midline, and I typically only do it for this very, very small portion from the chin to the hyoid bone. And if you don't know where your hyoid bone is, it's a bone in your neck that you can feel where the chin basically turns into the neck.
Yeah, where the trachea starts.
Yes, and it's right there, and you can feel it. And so I like to sew that part together. I don't typically like to go below it because I think that makes more of a cobra neck deformity.
Yeah, the cobra neck deformity being where you have this really kind of sunken in, hollow neck and prominent bands that still exist.
Yeah, it makes the bands worse.
Makes the bands worse. But not everybody needs a platysmoplasty. Some people just need to have the platysma bands cut. As you mentioned, take a wedge out. If you just cut the bands, which it seems so obviously you have this big cord, you just cut it in half, it should go away. But as you referenced, it tends to grow back. So that's why most of us take a wedge, an actual little chunk of the muscle out. So theoretically, it doesn't grow back. And then you can choose to do the platysmoplasty, which is just sewing the muscles back together, as you referenced, just sort of at that superior aspect to sort of pull the chin and the neck up without creating that cobra deformity down low. Or you can choose to not. Some people don't need the platysmoplasty either. And that's just a very unique sort of patient diagnosis thing that you have to decide before you go into the surgery. So that's one option, to cut and sew, or cut and not sew.
In a lot of men, I will cut the platysma totally across.
Or you can cut it totally across.
I just go, take it out of action, and I'll bring it, to the mastoid back here, which is basically a structure on the side of your neck, where I'll sling it up that way and just leave the inferior portion, and that gets rid of platysma bands.
So why more so in men than women?
I think in men it's just they're so much more prominent. They're just like.
Yeah, if you have someone that has platysma bands like all the way across their neck and not just in the center, you kind of have to address the whole platysma, which, as you said, if you just cut the whole thing all the way across and disassociate it, the top from the bottom, kind of fixes the problem.
It does, and it works well, and it's easy to do. And then, then on top of that, with the deep neck work, you have to ask yourself, well, is it really the platysma band, or is it there's the anterior belly of the digastric muscles, which goes from your chin to the hyoid bone and then out to, the mastoid, to the stylomastoid frame, and basically the styloid process. So that digastric muscle, the anterior bellies can be divided, they can be sewn together. There's a lot you can do in the deep neck work. And again, I know that on, all the social media channels that surgeons are talking about these things as though everybody needs them. And so patients come in saying like, oh, I'm so worried about my glands. I'm like, you can't even see your glands. They're fine. I have a patient right now that's like, you just have to take them out because I think I need them out. And I'm like, okay, it's not without risk. You can get a sialocele, which is a collection of saliva that needs to be drained and treated. And there's a lot of like issues with these things. So doing them just to do them willy-nilly, I just don't think is a good idea.
Yeah, I saw a guy giving a talk about that at MCAS. He was, I think he was from France, actually. He was from somewhere in Europe. And he was talking, and he actually put up like America as like a standalone entity with facelifts. And he's like, in America, they're doing these very aggressive, deep neck and face work. He's like, and my argument is that you don't necessarily need all of that. It comes with complications. But he put America up as a singular entity known for being aggressive with the necks.
Because the surgeons have chosen to differentiate themselves on the fact that they do these things. Like it's some miracle, and it's not. And, this is where I'm not gonna get on the box. Okay. I know you can see me going to get the box right now. I'm going to bring it in here. I'm going to stand up onto it. I know you can see that right now, but I'm not going to do it. But I do think that patients should understand that just because social media, like there are social media like crazes about plastic surgery that happen all the time. Like there are social media diseases that are created by non-science and just posting, reposting, and fomenting some like crazy thoughts in people's head, like so that my patient walks in and says, I'm really worried about my glands.
You're like, I'm not.
You can't even see them. They're not there. Yeah. They're up under your mandible where they belong. When they drop down 30 years from now, then we can go after them and do something with them. But why would you not want your saliva? And why do you want the risk of that procedure when it's a non-entity? It's like saying you should take out my thymus gland because I think it's gotten too big. Have you ever thought that?
I have never thought that.
Have you ever thought to have your thymus out?
I've never had that thought.
Right now, people are Googling thymus gland and going like, why would you need your thymus gland out?
You don't.
But that's the thing. You could make that into like could you imagine people are like, the thymus must be stopped. I mean, you could totally get everybody in the world to think that way.
A super deep neck.
That's like the deep neck.
Deep neck.
Although people do always ask me, they say, well, how far do you dissect down? I say, well, when I see the innominate vein, I think I've gone far enough in the neck. But, that's...
surgical anatomy humor.
That's a little geeky joke for the surgeons in the audience. But I do think that it is of concern that patients are whacked over the head and that the scientific surgical information is weaponized against them to think that they need to do these things.
Yes.
You agree?
You can step down now.
Okay. I was trying not to get up there. And I still got up.
You still got up. And you made your point. Yes, the deep plane or the deep neck work is not always necessary in every patient, especially if all we're talking about is the platysma. You don't need any of that deep work. No. We're talking about a very, very, very superficial structure and the ways that you treat it. And the fact that you can do all of these things and individualize the surgery and do all these cool tips and tricks, and you still have bands.
So typically we make a small incision in the submental region, but you can also do a lot for the neck from the facelift incisions.
Mm-hmm.
Does everybody need an open neck, Dr. Rovelo?
No, not necessarily. Sometimes you can make it worse. But
True.
I like an open neck because I can
too.
see everything, especially since most of the problem is usually there in the center and I can sort of attack the issues. But there are some people that say you don't need to open the neck, especially if the neck really isn't a big problem.
Right.
Then you can address a lot of the issues and just do a neck lift or a facelift from the incisions on the side. But if the bands and the central neck are at all an issue, then I prefer to have an incision under the chin there.
Yeah, and it's easy to do, and
It's easy.
you know,
If
for
you're
us,
looking right at it, like
yeah.
it's very helpful.
What do you do laterally with the platysma? What's your
Laterally, well, so the
your maneuver?
the platysma is in continuation with the SMAS. So I'm already doing some kind of deep plane SMAS. It's connected with the platysma, so it's all one unit that's being addressed. But I typically split the platysma under the mandible, under the jaw, and I can therefore pull it in the angle and in the direction and the vector that I want it to be. And like you said, suture it to the mastoid behind the ear there to get a nice pull on the neck. So I usually do a little bit of subplatysmal dissection up laterally, cut it to the area that I want, and then give it a nice pull.
And you're a deep plane facelift gal, yes?
Yeah.
You- more than, what about like in revision faces, if they've had some sort of SMAS work, or you SMAS plication, SMASectomy, what do you like to do in the revision faces?
Depends. You know,
See,
it's a
there you
big
go.
fat.
It
It depends. You know, if you know that they haven't had any deep plane work, sometimes it's nice to go in there and elevate the SMAS. It's a little tricky.
It's harder.
It's harder. Or you can just plicate and just kind of tack it up and do some skin only stuff. But it depends. And if it's one of your patients and you know what you've done, it's a little bit easier.
For sure.
Yeah.
But yeah, sometimes you can do a deep plane on a revision
Yeah.
face, unless they've had a high SMAS flap or a deep plane.
Then you can't
previously.
do that.
It's really
Yeah.
hard to do because the glide plane is kind of gone.
Right.
You know, that's the thing. So these are all technical terms. Since everybody watches, these things on Instagram, we're using them. So you all can just get right in there with us. But laterally, I do the same thing. I like to split the platysma off the SMAS, bring it to the mastoid. If I do divide the platysma all the way across, then I'll bring the upper part of the platysma to the mastoid fascia and sew it up there.
Yep. And what do you do if the bands come back?
Cry.
Yeah.
You should say, when the bands come back, what do you do? How about that? Is that the right statement?
That might be, yeah.
Because, they freaking grow back.
They grow back.
They do. They do
do.
something about it. They just,
I know.
people get that period of time where there's no bands and you're just like, oh, this looks amazing. And then all of a sudden it's like,
And then they are. And they're never as bad as they
And
were
there they
before. It's like one area or two areas. So you can go back in and cut them. But a lot of times I'm just like, let's just Botox them. You can, before you even get to the facelift, neck lift stage, if you're not there yet, you can just Botox these things and you can Botox them again after surgery. It takes a decent amount of Botox, and like Botox, you have to keep doing it. Otherwise, it comes back. But that is the non-surgical option of addressing these.
yeah, it is. It's very frustrating when they come back. I just want to cry. Basically, it's like,
And you can go back in. You can open up
can.
that central incision, especially if there's just one or two bands that you can see. You can cut them again. It's not a big deal, but it is annoying.
yeah, I like to take them out. I really do like to excise a lot of the platysma, though.
Yeah.
That muscle is it's my nemesis. It's
Necks are hard.
and I will tell you that revision necks are not easy.
No, and the thing is, because this muscle is so superficial, the skin of the neck is so thin, it doesn't take much for the neck skin to stick to the surgical areas
Yep.
and to the surgical sites and to the areas that you worked on. And it just gets stuck, and you really got to help the patient and work with them and teach them massage maneuvers and different things they can do to help break up those scar bands. But yeah, the neck, it really doesn't like being messed with.
No, and it fights back sometimes. You
Yeah.
can get a lot of very uneven healing. You get lumpy bumpies. You can get all kinds of issues that, and I always kind of like talking my patients down. I'm like, look, you got to be patient with this, because if it's a revision neck, I always kind of warm them up to the idea that this is going to be difficult.
Mm-hmm.
There is a certain amount of blowback that you're going to have to deal with from these revision next. They're not simple.
Right. So it's like, what can you tolerate?
Yeah.
How bad do those bands bother you? Yeah.
Yeah, and that's just, that's part of it. But which again, why I tell people like pick the right surgeon, make sure that they get, really nice results, they have great before and afters, and that they're willing to deal with the problems that come up from these, issues. If you're flying in for these operations, which a lot of people do, then you kind of got to be ready to fly back if something comes up.
Very true.
Don't you think?
Absolutely. Nothing's a guarantee.
No. There are no guarantees in surgery, and these things are hard. They're challenging to get them to work, especially Platysmal Bands.
Our nemesis.
Yes. And they can wreck your amazing facelift if like you do this incredible work and the face is heart-shaped and your brow lift goes great and look at those lids, and then
there's that band and you're like, gosh darn it.
didn't I cut you in the surgery? Don't I remember I remember putting an Alice on there and taking a big wedge of that platysma muscle out and throwing it into the trash. Like, there it is.
Yeah. Platysma doesn't care.
Platysma don't play.
No.
It's so true. Well, hopefully then the next time that we have to talk about Platysmal Bands, we'll say, you know what? Eureka, we have it. This is how you solve the Platysmal Band issue for good.
Yes. But until then,
you deal with it. Anything else on Platysmal Bands?
No, I think that's it.
Well, then why don't you take us out of here?
This is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.